It's an honor to talk about the Peters principle. What is that, the Peters principle? Well, I guess most of you are familiar with the Peter principle. The Peter principle is where people in an organization keep on being promoted up into a certain level where they reach a point where they're beyond their own competence. So they should actually perform better if they were demoted, but nobody does it. So you end it with a couple of incompetent fools at the top of your organization, and your organization or your company fails. That's basically the Peter principle. But there are other principles. For instance, this one. Oh, I hear you think, where have I seen that before? It is the Heisenberg uncertainty principle from quantum mechanics. And it basically means that the product of the momentum of a particle, for instance, an electron, multiplied by its position, has to be larger or equal to the Planck constant divided by 2, which basically means that, well, you can either know the location of a particle or its momentum, but not both at the same time. That's the Heisenberg principle. And here I am with Professor Heisenberg in 1934, discussing that principle and how we can apply it to diabetic foot infections. So what I would like to talk to you about is, well, I'll touch a bit on the Peter principle. So what will happen if we reach the post-antibiotic era? What will happen if we've promoted antibiotics beyond their level of competence? And also the Peters principle. What are the uncertainties in diabetic foot infections that we need to address? So we can talk about antibiotics. What type of antibiotics are you supposed to give? How do you give them? How long? And do you need to do surgery versus antibiotics? Now, I did not talk to Professor Lipsky before this meeting, so there's obviously some overlap also with the other speakers in this session. So what type of antibiotics do we need to choose? Well, last week, one of the residents came to me and said, you know, I have this swab results of an ulcer of a patient with a diabetic foot infection. So what type of antibiotics would you suggest I would suggest to the surgeon to give? And she suggested a couple of options, namely clindamycin, flucloxacillin, ciprofloxacin, clindamycin, and ciprofloxacin or meropenem. And what grew in the wound was, well, you can see it on the lower right side of the screen, was Staph aureus, some epidermal staphylococci, and gram-negative rods with different resistance profiles. And, well, I don't know what you would advise the resident to give, but I answered, and I then paraphrase Mark Twain. I answered, well, that I can answer, I said, and I did, and I said I didn't know. I don't have a clue. I don't know what to give those patients. I don't know what to advise those patients because there's a lot of stuff that I don't know about this patient and about this ulcer. And I'll get to that in a minute. At first, I'm from Europe, and this is a map of Europe with an overlay of the United States. And I live in that very small country right next to Germany on the North Sea, right next to the UK as well, and north of Belgium. And there are differences between our countries. There's more than one difference. And there's social differences, like you can see here, but also there are differences in the way the medicine is set up, the medical system is set up, and also, of course, there are differences in resistance profile of bacteria. So in the 40s, we were given the gift of penicillin, and soon resistance developed. So if you look at Staph aureus, for instance, in the early 50s, resistance to penicillin has been described, and after that, in the 2000, even vancomycin-resistant Staph aureus has been described in the literature. And it wouldn't surprise you, ladies and gentlemen, that the first 7 cases were in diabetic foot infections. Now, within Europe, there are a lot of differences. If you look at this slide, it's a slide from the European CDC, and it shows you the proportion of third-generation cephalosporin resistance of Klebsiella pneumoniae. And as you can see in the north of Europe, there's hardly any resistance to, say, ceftriaxone or ceftazidime. But in the south of Europe, there's a lot of resistance, even more than 50%. Once again, this is where I live, Amsterdam. And if you look at carbapenem-resistant Klebsiella, the differences are even greater. Personally, I've never seen a carbapenem-resistant organism in my hospital, but if you look at Greece, for instance, well, more than 50% of the Klebsiella species are resistant to carbapenems. So I can imagine that since there's a lot of differences within Europe, there must be a lot of differences in America as well, and differences between America and Europe. So if we could then go back to the patient of whom I was shown the resistance patterns. Are all diabetic foot infections polymicrobial? Well, I don't think that they are. And one of the reasons I don't think that they are is a study that Professor Lipsky has performed to linezolid versus ampicillin and sulbactam in diabetic foot infections, a multi-center trial. And the cure rates between the two groups of patients that were given these drugs were not significantly different. But if you then look in more detail to the results, and look at the wounds that grew Staph aureus, you see that in MSSA, so methicillin-susceptible Staph aureus, there were no differences between the linezolid and the aminopenicillin and beta-lactamase group. If you then looked at MRSA, of course, the linezolid group performed better than the aminopenicillin and beta-lactamase group, which makes sense because linezolid has activity against MRSA and aminopenicillin and beta-lactamase does not. If you then look further, you see something striking, because if there's Pseudomonas or other gram-negative rods in a wound, then still the people that were given linezolid did well, 80% healed, and in the aminopenicillin and beta-lactamase group, 64 and 70% healed. And that's strange, because linezolid doesn't have any activity against gram-negative rods. So if you think that, then Ben Lipsky and Tony Behrens have come up with the allegory of the head of the cobra, where the head of the snake with its fangs and its poison represents Staph aureus and streptococci, and the tail of the snake would represent gram-negative rods, anaerobes, and skin flora. And if you would then give a patient an antibiotic targeted to the head of the snake, then you're left with an innocent tail. Now, that might be very true, but we don't have any exact data on that. So, but I guess it's safe to say that in mild infections, it's safe to just target your antibiotic to gram-positive cocci. And that's good, because that will save us some antibiotics. So our hospitals will have less trouble with resistant organisms. Now, this slide, and I'll go over it real quick because it has been described in more detail. This is a study from the south of France, from Nîmes, where they decided to adhere to the International Working Group guidelines. And they decided to do only tissue swabs and deep swabs and leave out the superficial swabs. And what they saw was that the amount of bacteria that they got back from the lab decreased from, say, around 4 to 2, and that the number of multi-drug resistant organisms decreased dramatically, probably because they targeted their antibiotics towards the pathogens and not just to the colonizing agents. But that's my own assumption. Now, in the Netherlands, we've done a study to the effectiveness of the standard treatment for diabetic foot infections. And in the Netherlands at the time, most surgeons gave a combination of clindamycin and ciprofloxacin to any patient that came in with a diabetic foot infection. And what we found that in our hospital, 20% of the patients had Staph aureus or gram-negative rod that was not susceptible to both of the drugs, so either of the drugs that were given. So that means that 1 in 5 patients were given useless antibiotics. So we changed that. We changed that now to a regimen that covers the most common organisms and their resistance profile. Now, how can we further prevent antibiotic resistance? Well, I've taken this picture. I've anonymized these two doctors, but you will probably recognize one of them, the one on the right. You can tell because, of his lush hair that's radiating from his scalp. It's me! No, it's not, but it could have been me. And why I show you this slide is that I think that this is a staged photograph. This doctor did not come from a patient. That cannot be possible. Why? Because he's wearing a wedding band, even though he has a beautiful wife, but still he does. He has a watch, and he wears long sleeves. So he must have just put on the lab coat because a picture was going to be taken. He did not come from a patient. Why shouldn't you wear these? Well, of course, because if you wear these items and if you wear long sleeves, you're more likely to transmit resistant bacteria to your patients. So which type of antibiotic should we use then? Is there a silver bullet that we can use? Well, like I just said, you have to look at your own resistance profile in your own hospital, in your own environment. The IDSA guidelines 2012 have given some options. I will not go over them, but you can look them up in clinical infectious diseases. On the left side of that table, there are a couple of antibiotics that you could use, that are suggested you could use, and on the right side are practical issues that you can look at before you prescribe it. For instance, if you look at clindamycin, well, it's usually active against community-acquired MRSA, but you have to check for macrolide sensitivity. Well, there's something that can be said about all these antibiotics, and none of them is the silver bullet. So how long should we then give antibiotics? Professor Lipsky has already taught us something about that. What we both did with a couple of other people in the International Working Group Diabetic Foot is that we performed a systematic review to the effectiveness of interventions in the management of infection in diabetic foot. And what we did was we reviewed 7,500 articles, and we came up with only 12 trials to antibiotics, of which 7 were in osteomyelitis, diabetic foot osteomyelitis. And globally, there were no differences between antibiotic regimens. The duration of antibiotics in those trials ranged from 6 to 27 days in skin and soft tissue infection, and if patients with osteomyelitis were included, in 6 to 28 days. And there were only few studies with oral regimens, and those antibiotics were given for 2 weeks. The clinical cure rates for skin and soft tissue infection ranged from 48 to 90%, and if you included patients with osteomyelitis, about the same, 61 to 94%. As you probably notice, this is probably a little less than what we usually give our patients. I mean, not as long as that we usually give our patients, 6 to 27 days. Now, there were also some non-controlled studies that we've identified where they did non-surgical treatment of osteomyelitis with very long courses of antibiotics, 3 to 6 months, and the clinical success rate was comparable. Then, how long should you give antibiotics and how long? Well, predominantly that's based on expert opinion. You can read about it in the IDSA guidelines, and it ranges from, say, 1 to 2 weeks in mild infections, superficial infections, to more than 3 months if you haven't performed any surgery in a wound and if you've left a lot of dead bone within the wound. Now, next question is, if we then would like to save as many antibiotics as we can, why don't we do as much surgery as we can? will outcomes improve if we do more surgery, or will outcomes improve if we do a lot of non-surgical interventions? Now, Professor Lipsky has already told you something about that. Also, the fist fight that Fran Game and Dr. Argon Sanchez had, and where he was caught in between. But in that systematic review, we found 2 single-center cohort studies that looked at early surgery and antibiotics, and they found that there were non-randomized studies and non-controlled, well, they were controlled, but they were non-randomized, and they found a significant reduction of major amputation ranging from 27 to 13% in one study and 8 to 0% in another. Well, how about osteomyelitis then? Because that was skin and soft tissue infection and osteomyelitis combined. How about osteomyelitis? Well, there have been 3 studies, more or less, a case series that looked at surgery in osteomyelitis. One by Havan in 1996, one by Henke in 2005, and one by Aragon Sanchez, 2008. And basically, the outcomes showed that the healing rate ranged from 56 to 78%, and the duration until healing was 181 days. One of these studies had a historic control group as a control parameter, and the patients in the historic control group did a lot worse. So that's why one of the conclusions was that patients without surgery did worse than patients with surgery. But in the team of Frank Game, there were also a couple of studies, for instance, one by Frank Game herself in 2008, one by Eric Sanville from France in 2008, and one British one from 2013. And it wouldn't surprise you that the outcomes that they produced were about the same. 58 to 67% healed, and the mean duration of treatment was 2 to about 3 months. So what was needed then? Well, a trial probably, because both of these strategies had reasonable performance, but they were case series. They were not controlled, not randomized. And it was found that the choice of treatment was based not on the circumstances that the patient was in, but more or less on the preference and the training of the physician. So this study was published very recently, a trial to antibiotics versus conservative treatment for diabetic foot osteomyelitis. And Professor Lipsky has already told us something about that. In general, if you look at all the patients, there were no statistically significant differences. But there were some limitations to the study. For instance, the diagnosis of osteomyelitis was based on probe to bone and X-ray, not on bone biopsy. And there was likely to be selection bias because they screened a lot of people and didn't include everybody. And how about the generalizability then? Can we apply those data to the patients that we see in daily practice? Well, if I then summarize my talk, if we look at antibiotics, there's no silver bullet. I have to disappoint you again. Please treat as narrow and as short as possible, as narrow spectrum and as short duration as possible to prevent resistance from occurring in your hospital. And if we look at antibiotic competency, know your local resistance patterns, so you don't overuse antibiotics, but you don't underuse them either. There's no optimal route. We can give them IV or orally, depending on the situation of the patients. And how long? Well, that's based on expert opinion. There are going to be more studies to that issue. Look at cultures, take tissue samples, don't use swabs. And antibiotics versus surgery, well, there's been one nice trial, but that's no definite answer yet. We need more studies. So with the equation of Heisenberg, I'll leave you, and I hope to see you in Utrecht in the Netherlands at the European Bone and Joint Infection Society meeting in September, where a part of it will be on the diabetic foot, or in The Hague in the formerly known Noordwijkerhout meeting in 2015. Thank you.